Perfect. So, Sydney, if you want to put up that first slide, we'll kind of slowly get started here with some introductions, and hopefully other people are going to join us over their lunch hour. Of course, it is recorded. So if you want to share this with any of your colleagues after the fact, we'll send out the recording in a bit. So let's start with just a quick agenda that we have today. First of all, as you will notice, Elena is not on this call. You guys got the announcement last month that she took a position in public health in her home state of Vermont. A lot of you probably knew this, but some maybe didn't, is that for the duration of Elena's work with us, she actually lived in Vermont. She wasn't in Colorado. And although she joined us for in-person events, that's where she lived. And so she took a position there in public health and is continuing her great work in maternal health. In her absence, we have welcomed our new program coordinator, Sydney. And so I'd love to give Sydney just a minute to introduce herself to you all, because you've probably already received emails from her.
Hi, everyone. Yeah, like Amber said, my name is Sydney. I'm the new program coordinator here for CPCQC. I am really excited to start work here. I just did the drive from the East Coast. I'm originally from just outside of DC in Bethesda, Kensington, Maryland area. And I just did the drive out to Colorado. So I'm now here in Estes Park. And I'm just really excited to be working with you all. Please feel free to reach out to me if you have any questions, concerns, thoughts, whatever. And yeah, sounds great.
Perfect. Sydney is our all person go-to for anything logistics. And so if you're ever confused about who you might want to ask questions to, you can always start with Sydney, and she can get you to who you need to. And then all of your programmatic and emails will likely come from her from here on out. So make sure that you're receiving them and that your filter's not blocking them. And if you're having any trouble receiving emails, then definitely let us know and we'll do some work on our part. So just as an overview of what we want to do today, we're going to start, of course, with a little bit of lived experience, and we do that in a form of a video from the Tough Mother organization. Again, we use these at the beginning of our coaching calls just to center us a bit in the work, remind us why we're here, and hear from those who have actually experienced substance use. Then we're going to have a short presentation on quality improvement. As you guys know, we have worked our way now 7 months through the sort of basic principles of quality improvement to help you guys have the tools that you need. So we're going to talk about measures for improvement today, and then we're going to end by actually hearing from Rose Hospital, some of the work that they're doing, the successes that they've had, their PDSA cycles, and so we're super looking forward to hearing them present. We'll have some time at the end for Q&A. So if you're just arriving, chat in your name, maybe which facility you're at, your preferred pronouns, and we'll go ahead and get started with our video.
Can everyone see that okay?
I've had a friend overdose. We were using together. It was very scary, but luckily I knew what to do. I knew what naloxone was. I knew that it had saved my life. I knew it had saved my baby's life. The situation with my daughter, she overdosed September 27th, 2020. She was in her father's care, and she got in a hold of one of his pressed fentanyl pills, and she ate it. He did not have Narcan on hand. Luckily, my daughter clung to life long enough for her to receive that Narcan from the emergency room. I happened to get the call about it on my birthday, and later that night, I actually overdosed myself. I should not be here, but I am. So I am very grateful for that.
We chose the word tough to describe moms because moms, just like anybody else, are subject to struggle with a substance use disorder. And we wanted to speak to that inner strength, that inner ferociousness, that unyielding, unwavering strength that moms possess, to remind them that even though parenting is hard, even though struggling with a substance use disorder is hard, that moms are tough and they are tough enough to overcome addiction. That message goes so well with the mission of the Moms Initiative which is to put naloxone into the hands of every pregnant and postpartum birthing family before they leave a hospital or a birth center.
So this is what a naloxone kit might look like. You have a nasal atomizer here. You would insert that tip in someone's nose and spray the medication into their nose. We actually have a lot of great vasculature in our nose where this is absorbed almost immediately and becomes effective. If the patient's not breathing, doesn't have a heartbeat, super important to do CPR so that you circulate the medication throughout their entire system and make it even more effective.
Very safe to give to people of all ages and sizes, and safe to give even if we're not sure the exact circumstance. So we like to educate our patients so that if you come upon a person who is unconscious, they're not breathing, they're breathing very slowly, and you really don't know what may have happened, it is still safe to give this medication. It will only reverse an opioid overdose, but it will not cause any harm if a person is unconscious from another medical or another substance cause.
It's safe for pregnant women. It's safe for postpartum women. It's safe for babies, kids, elderly. It's safe for pets. I know folks that have reversed their pets with this. It's completely safe to administer this. If they did not ingest opioids, it will not harm them. If they did ingest opioids, it will save their life. And so it's definitely an automatic no-brainer. Don't ever hesitate to administer naloxone.
There seems to be a particular concern and sometimes feeling of helplessness of how to take care of people with active substance use. And providing naloxone helps to build that bridge, right? It's saying, I care about you just as you are. You don't have to get sober to matter, right? Your life is just as valuable now as it would be if you were a person in long-term recovery. And I want you to live. I want you to have this life-saving medication so that in case of emergency, you or someone that you know is able to reverse an opioid overdose event.
It gives you an opportunity to have a conversation. I think naloxone says that I care about whether or not you live or die because I can't help anybody, especially with what I do. I can't help anybody who isn't here, period. I need you to be alive and breathing for you to recover.
Anytime that anyone has any kind of opiate in their home, period, for anything, they should have Narcan. I mean, I think that kids should carry it in their backpack at school. You never know if you're going to walk into the bathroom and find someone that's overdosed.
You know, it's like peanut butter and jelly. If you're giving a mother opiates, whether it be in labor and delivery or sending them home with a prescription, they need to be sent home with Narcan.
Moms and people are worth saving. Their lives matter. And naloxone is a really common sense option to be able to save people's lives.
Tough moms carry naloxone.
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 Thanks, team, for allowing us to begin with that sort of centering video. I know many of you as champions for Coambs SUD at your facilities are familiar with naloxone, and we really trust that you all are sharing this message with your staff. And if you need other resources for educating your staff about naloxone, or if you need site visits from the Colorado Naloxone Project or the Tough Moms crew, we're happy to facilitate those for you. I'll be honest, as an obstetric care provider and a prescriber for the past 10 years, naloxone felt scary to me. I had never prescribed it prior to the past couple of years. I recently attended some of the trainings from the MOMS team, and just having it demystified, right? Touching the box, holding the actual administration canister, learning how you can educate your patients on how to use it. It really felt much more, I had much more confidence about prescribing it. And I had the opportunity this past weekend at my hospital working in the screening room to distribute naloxone for the first time. And I'll tell you, just as Dr. Klee said in this video, it's very empowering to be able to do something tangible. I think some of the struggle as obstetric providers we have with patients who are experiencing substance use is feeling like we can't fix it and we can't fix it immediately, right? We know that substance use is a treatable disorder, but it's not something that's quickly treated. And when we have these shorter interactions with patients, maybe during the birth admission, during a prenatal visit. Sometimes it feels like it's so big and there's so little that you can do in that interaction. And naloxone is a bridge, right? It opens the conversation. It lets the patients know that you really care about them. You want to give them something that will keep them safe. And so it was really special to me recently to sort of be able to experience that story that I've heard the moms team say so many times. We recently had the Colorado Naloxone Project visit a couple of our sites, and they went to a midwifery department meeting. They went to a nursing department meeting and did a demonstration and gave naloxone kits to the staff, and so that everyone has a kit to carry. Again, it sort of demystifies just having it on hand. And so again, if that's something that hasn't happened in your institution and you think your staff would benefit from it, please reach out to us and we'll arrange that for you. All right, let's go into the next slide. For those of you that have been with us for the year, we are now in our 7th month of talking about some of the basic principles of quality improvement. I again like to center our talk about quality improvement in the why of what we're doing it. Quality improvement can feel not super sexy, right? And so I think it doesn't have to be sexy to be important, and it's really important in the state of Colorado. And so we're here because suicide, unintended drug overdose are the leading causes that are killing pregnant and postpartum people in our state. And that the Colorado Maternal Mortality Review Committee is telling us that 80% of those deaths can be prevented, meaning that we have the power to impact patient care to save lives. And the reason that we're using quality improvement framework to do that is because it's the quickest way to put research into practice, to have a direct care plan in order to address these issues. And so we have gone through sort of stepwise exactly what we mean when we say quality improvement. So we'll go to the next slide. At CPCQC, we do that using the Institute of Healthcare Improvements model for improvement. And it's this model that we've been working through over these months. We first started out by talking about a mission and vision and how important that is for your team, for getting buy-in from your team and making sure that you're all centered on the same issues. We also talked about making aim statements and being very specific with your team about what you're working towards, making sure that it's measurable, that it's clear who your audience and your target is, and that you all are focused on the same goals. And then we also spent some time talking about change ideas. So what is it? What are the ideas, or what does the research say will impact patient care for perinatal substance use? And are those research facts and change ideas applicable to your institution? We've talked through several different tools for change ideas. We talked about the 5 whys when you at your site encounter an improvement opportunity for patient care, and you're sort of wondering, what is it? How is it that we can best tackle this? If you ask your team why 5 times, right? Why is it that patients are leaving the hospital without a discharge visit scheduled? And then go down that list, right? Ask your team why. The first thing they tell you, you say why to that. The second thing they tell you, you say why to that. And those 5 whys will really bring you back down to sort of a baseline actionable step that gets at the heart of that problem. And then we'll go to the next slide because we talked a lot about driver diagrams. And so I'm not going to talk you through this, but I encourage your team, if you have a few minutes, to have a driver diagram that's specific to your site, because this really nails down within your specific facility, within your staff, within your health system, what are the drivers to providing good quality care for perinatal substance use, and how exactly should you be addressing those to make your time and your effort the most useful. So again, these slides will be shared out later. I'm not going to go into in depth. This is just a review that these are available to you, and we've already talked about this. So moving on to the next slide, what I really want to move towards today is the third and last of those top questions that we need to answer in order to address quality improvement. We already talked about what it is we're trying to accomplish. We already talked about what change ideas that we can make to result in improvement. And now what I want to talk briefly about is how is it that we're going to know if those change ideas and those changes resulted in improvement? And this is where we talk about measurement. Data is so important to quality improvement. The sort of the quality improvement principle is that if you can't measure it, you can't improvement. there's no way for you to know if the actions that you're putting into place are actually improving patient outcomes unless you're able to get data. And I think it's important for our teams, because we ask you to submit data and we know that that requires your time and effort. And we're so appreciative of the data that you submit to us. I think it's important for us to explain to you why it is that we're collecting that data and how we're using that data in our quality improvement programs. So I'll go to the next slide. And I really want to use these just to highlight for you that, one, there's a difference between data for research and data for quality improvement. And that sort of, in this left cartoon kind of gets at the heart of this, that for research, it's acquiring new knowledge, right? We're acquiring as much data as possible in order to generate new evidence for healthcare practices. And so for research purposes, the more data, the better, right? Whereas for quality improvement, the way that we use data is to say, have we made improvements or not? And that's it. Right? We're not acquiring new evidence. We're not coming up with new ideas. We're seeing if putting that research into action is useful or not. And so for quality improvement purposes, it's not the more data, the better, right? We are very specific about the data that we collect, because if it isn't useful to the quality improvement steps that you're taking, it isn't useful for you to be collecting and submitting to us. And so quality improvement tends to be very judicious in the data that it collects. And we're going to talk about some of the measures and how we sort of get a very balanced set of data in order to make good quality improvement decisions. And then the second cartoon here gets at the point that we don't actually just measure things to measure them. Like, there's no point in saying we're good at measuring things and here are sort of what our data says if we're not going to act upon them. And so a measurement isn't useful unless we actually have a plan to act upon the data that it's giving us. So now we can go to the next slide. In quality improvement, we have what we call a family of measures. And so it's usually a set of different types of measurements that we use to guide quality improvement work. And it looks at this system from several different angles and perspectives. So the measures that are often, but not always, included in every quality improvement program are process measures. These types of measures tell us, are the parts or the steps that you're performing working as planned? Or this tells you sort of the inner workings of the system. I like to think of these as, what is it that you're asking of your healthcare providers or your staff to do? And are those steps actually happening? So processes is what you're asking your staff to do actually happening? And is there room for improvement there? The second type of measures that we collect are outcome measures. And these are the measures that everyone is interested in, right? Everyone wants to know, what is the end outcome of the quality improvement, right? Have we actually impacted maternal mortality? Have we identified perinatal substance use? Have we lowered a C-section rate? Right? So these are the ones that are sort of the most publishable, or the ones that people want to know about and share out, but they're not always the most important ones, right? And so I think that I hope that at the end of this talk, you can see that even though outcome measures are what sort of the end goal is and what your external audience often wants to hear about, these other measures, these other sets of family measures are just as important to ensuring that the quality improvement program and the steps that you're putting into place are actually working. The other type of measure is a structure measure. These are really big measures. These are the type of measures that support sustaining a quality improvement program. So these are the things that are impacting the system's capacity for quality improvement and sustaining the quality improvement that you're doing. They assess the embedded practices that are necessary for continuing this care beyond the life of your quality improvement program. And then finally, balancing measures are very important for quality improvement. These are the types of measures that tell us, are we doing more harm than good? Right? By impacting one part of a system, are we actually harming another part of the system? And are there unintended consequences to us making improvements in one area? Not every quality improvement project has all four of these classes of measurements, but a really good quality improvement usually has at least three of the four. And so I hope that, beyond this program, SUD, you guys are working on quality improvement efforts in your facility. And if I gave any advice at all, it's to make sure that what you're measuring has some balanced perspective here and uses more than just one or two of these classes of measurements to guide your work. So on the next slide, what I want to do is show you, of the data that you are collecting and submitting to us, what types of measures are those? Where do they fit into the system? And how are we using those? Because again, we don't want to be collecting data for the fun of it. And we're not just proving that we can measure things because we can. These are actually useful measures that we're using in order to guide your care. So we'll go to the next slide, Sydney. And on this slide, I haven't, sorry, back one. Tricky. On this slide, I haven't included every single measure in this entire program. For those of you who input our data, you know that this isn't a comprehensive list of the data that we require of you, but it's a pretty good snapshot of what the SUD program looks at when we measure the success and opportunities for improvement. So under our process measures, this is where we're asking you about your screening rates, about if your providers are counseling on recovery treatment services, if they're receiving a social work consultation prior to discharge, if you all are distributing naloxone appropriately to high-risk patients, and if you're able to initiate MOUD care during the hospital birth admission. And again, I want you to take back to these are the steps that are required of your staff, right? Process measures tell you, is the process working as it's intended in a way that will support the outcomes that we want? Moving on, our outcome measures, again, these are the big picture ones. We don't always have these measures on a quarterly basis. Sometimes it's years before you know population level data, like is SUD, is our efforts to improve care for perinatal substance use, is that actually impacting maternal mortality in our state? That's not a quick fix. We're not going to know that every quarter, even maybe every year. That's something that's a longer term goal. And this is why we can't solely rely upon outcome measures for quality improvement. In our program, another outcome measure is we track the number of positive screens that are identified. So that's a shorter term outcome measure that we're able to use for your teams in order to know, is the system working? Are you actually addressing the types of patient care that can contribute to maternal mortality? Moving on to structure measures. So again, remember, structure measures are big picture system-wide measures that we're looking at to make sure that you are working towards quality improvement that's sustainable in your system. For that, this is why we ask you if you have a process for resource mapping and a resource mapping document at your facility. This is why we're really encouraging you to have functional multidisciplinary work groups. And this is also why we work towards policy changes, like policy around toxicology testing, policy around opioid use and opioid prescribing practices at your facility, and pain management guidelines in labor to support evidence-based medicine for opioid use. So again, these are the types of measures that are big, they're long-lasting. These are the things that are going to sustain the work beyond the technical quality improvement cycle for your site. And finally, balancing measures. Again, this is us ensuring that we're not doing more harm than good, or by improving one area of care, we're not having harms in other areas of care. In this program, we don't have a ton of balancing measures. Not every program has a robust list of balancing measures. The two main ones that we rely upon are the infant's disposition, right? Are we negatively impacting the number of infants that are discharged home with their parents or under their parental care? I think these are the types of things that we worry about with CPS reporting, especially if we look at disparities in care related to CPS reporting. Are infants disproportionately being not discharged with a parent or a family member due to the care that we're doing here? And then finally, the other balancing measure that we look at with the data that you submit to us is the number of patients that are discharged against medical advice, right? And with that, we're getting at, is the type of care that we're giving during the birth admission contributing to patients leaving the hospital prior to you being able to finish their care in a medically safe way? And so again, those are sort of measures that for you might not feel very applicable to the work that you're doing, right? It's not directly related to the care that you're giving. It's not directly related to maternal mortality, but those are definitely things that we want to make sure that they're not disproportionately increasing as we're trying to save maternal lives. I am going to do a brief pause just on this slide, just to see if you have questions. I know you all are intimately aware of the data that you're collecting, and the way that we present your data back to you in your data dashboards. Some of this data isn't in your data dashboard. You'll realize that we don't actually report back to you the infant disposition on your dashboard, but it is something that we look at, and we notify facilities if we see an increase in that rate. So I just want to pause for a minute and see, are there questions about the measures that we're using in this program, or do you have any feedback on how we're collecting those measures? Sydney's reminding you that you can either type it or come off mute, and it's okay if you don't have questions too.
Hello.
Yep.
This is Lisa, and for the moment, I'm doing the data collection for moms and for the SUD project, and I just want to let other people know that the discrete numbers are very valid. I think sometimes a lot of our patients have some very complex situations, and so I'm glad there's a box at the bottom where you can write some details, because sometimes it's just hard to get the complete picture with discrete variables.
That's such a good point, Lisa. And actually, Sydney, that takes us to our next slide. That was such a perfect setup, Lisa, for this. Thank you for that. Which is that all measures have limitations, right? Like every single measure, no one measure is going to tell the entire patient story or the entire clinical course that your patient experienced in your facility. And so this is one of the reasons that we really encourage a family of measures or a group of well-balanced measures. The caveat I'll also give, which Lisa is lending towards, is that measures can tell a story, but they often tell an incomplete story, even if you're using balanced measures, right? And so you have to think, what is the story that's being told here? And what is the story that's not being captured here in the data that's available to us? And so, Lisa, you're right. We do give opportunities for you to do write-ins, because we know that even if we're using a well-balanced set of measures for quality improvement, it's not the complete story. And you can't always see every single clinical facet or every single sort of patient contributor to what's happening that's within your facility. And so I'll give those caveats that even though we use a balanced set of measures to guide our quality improvement work, and that's the data that we use to sort of see how well we're doing and if we should make changes in the care that we're working towards, they have limitations, that the clinicians who are caring for the patients still should have input on the measures. This is why we report your data back to you and hope that you are then reporting your data back to your frontline clinicians who are participating in your program, because the clinicians also have a valid story to tell that isn't always captured in the measures. And that's something that we hope and encourage you all to capture at your facilities and give us feedback on. I think what I like about measures the most, though, is that when you're in a facility and you're doing patient care, it's a really one-on-one experience. And the clinicians who are caring for that patient really can understand a more holistic story about what's happening with that patient's care. But when we think big picture about your entire unit, your entire hospital, your CPCQC cohort, or even our state, we really have to rely on the measures to tell the story of the patient, because we cannot be in the room as you are for every single patient's story to get that context. And so although these measures have limitations and they might leave some gaps in the patient's story or their clinical care course, it's really what we have when we're talking about large-scale quality improvement efforts. I'll open it again to see if anybody has any questions or thoughts on that. Oh, we're such a quiet group. We'll move on. We'll move on to the next slide, which is very familiar to you all. It's us just kindly encouraging you that one of the big goals for our group here at CPCQC is to ensure that each of our facilities has a multidisciplinary work group that's supporting you champions in this work. Many of our facilities have made such improvements this year, now have small groups that are meeting, are now doing great outreach efforts to get a multidisciplinary work group. I think Linda, coming up in a minute, might share a little bit about how her multidisciplinary work group works. But in the end of this year, we would love for at least 30% of our participating facilities to have a work group. And so again, we have resources to support you in that if you're in the beginning stages of building a group for yourselves. And so we have visuals that might help team members understand what it is you're asking of them or what the workflows might be for those work groups. We also have recruitment letters, pretty generic ones that you can individualize for your facility for outreach that really talks about the work that you're doing with your state's PQC and why this work is so important based on maternal mortality outcomes. And so we'll be happy to share out those resources if you're still either just building your group or if you feel like your group would benefit from more recruitment, especially from outpatient care providers, which tend to be a little bit harder to recruit for a multidisciplinary work group about inpatient care. And next slide. I think that's the end of quality improvement for today. In the coming weeks, we're going to talk a little bit more granular about data. We're going to have our data analyst, Gretchen, come in and talk to us a bit about visualizations for data and specifically run charts, right? So these are the charts that we report back to you all on your data dashboards. And there's some technicality that goes into interpreting them. And we want to make sure that you guys are well equipped at your site to know what it is that we're communicating to you when we give you a run chart back. So with that, I am going to turn it over. We have a guest speaker today that we are all very excited about. Let me just switch gears here, make sure that I have everything I need. Perfect. Okay. So we are very fortunate to have Linda from Rose Medical Center here with us. So Linda is the supervisor for the labor and delivery unit at her facility. She's worked in L&D for 22 years, and 18 of those years have been at Rose Medical Center. She recently stepped down from the director role to a supervisor role to have a better work-life balance, and we heartily support that here at CPCQC. But we are very much thankful that you're continuing on with your work in co-aid SUD, Linda, and so we're welcoming her to share a little bit about the work that she's doing at her facility.
Thanks, Amber, for the intro. I do have a few other people on the call as well that are from my work group. So I have Jennifer Richardson, so she's our administrative director. Valerie Hartford, she's our postpartum director. And Dr. Bradford, she's our OB champion that's on the call. So if you guys want to jump in and let me know if you guys, if you want to add anything to the presentation, that'd be great. If I'm missing anything. All right. We'll go to the next slide. All right, so just a brief overview of Rose Medical Center. So we do anywhere from 350 to 400 deliveries a month. Our payer mix, the majority is private insurance. We do have OB private practices. We have a few midwives. We do have OB hospitalists that are here 24/7. We also have OB residents as well. As far as our involvement with CPCQC, we were a part of the SOAR program when it originally started. And then since we were a part of the program, we've decreased our NTSB rate from 28% to 25% in the past 1.5 to 2 years, I believe it was. And then as far as starting this program, we started in March. We do have a multidisciplinary group of OB leadership. We have our case management team, quality, our OB hospitalists, we have education as well. But we do need to get more frontline staff in our group. Let's see here. And we also recently joined the Moms Plus program, so we're excited about that. We have our in-person site visit on Monday coming up. So as far as our team strengths go, we've increased our screening for our patients from 77% in Q4 to 88% in Q1 of this year. So we're happy about that. We definitely need to increase that a little bit more. We want to be 100% for sure. We do have some opportunities. So like I said, improving our screening and then also improving our training for our staff. We definitely have had some turnover recently. So we'd like to make sure that we have a good process for training all of our staff when they're onboarded. Improving our consult requests as well, making sure that our social work team is aware of that we have a positive screen and we need a consult. So we're working on that piece and improving on our naloxone distribution. We do have the process up and running. It's just that we need to get it, we need to hand out more to our patients. So, and then next steps as far as just setting up the postpartum appointments prior to discharge. So, yep, and then NICU involvement. Next slide. So a couple of the issues that I'm going to talk about today, that things that we want to work on. So like I said, our turnover has increased quite a bit in the past year. And so we want to make sure that we have a consistent process, that everybody's being taught the same thing upon orientation, and that everybody's doing the same thing on the floor. So let's see here. As far as our plan goes, we would like to offer the expert training and just process changes on HealthStream. So I was able to get, so I talked to Amber about this so that we'd be able to load some of your content into our HealthStream for our staff. And then also we'll probably plan on in the next month or so by 9/1, probably do in-person education as well. And this is where I want to onboard some of our more of our frontline staff, especially from postpartum, to help educate our staff about the process for screening and then also handing out the naloxone. So we'll do morning and evening sessions with our staff. We'll distribute a nurse knowledge quiz after December, and then we'll review how we did in September, October, and November after that re-education of all of our staff and getting everybody on the same page. Let's see here, and then we'll just evaluate. Have we, are we screening more? Did our screening rates go up? Are we handing out more naloxone? And then figure out how we're going to continue to do the in-person sessions as well. Next slide. And then our next problem is we need to increase our social work consults for patients that screen positive. So we want to include the SUD screening and how to request consults in our September in-services. Complete morning and evening sessions, well, that's where we're going to include that. And then we'll audit, right now I currently audit all of the screening tools. And then our social work will get back to myself and let me know if a screening, if they didn't receive a consult for a positive screen. So we'll continue to do that. And then the leadership will continue to follow up with the individual staff and coach about the importance of the SUD screening and consults. And then lessons learned, definitely we need frontline staff involved in our committee just to get more buy-in and also to help with education. So we'll schedule committee meetings on a regular basis. I think that's one thing that we've struggled with since we started with as well, is just making sure that we're being consistent with our meetings and that we do have good attendance because sometimes everybody gets busy and not really attended well. So we'll try to make sure that that happens. And then just next steps is the HealthStream education and in-services in September. And hopefully with all of this, we'll be able to improve our screening, our consults, and naloxone distribution. Any questions?
I have questions.
Yeah.
Thanks. We're always impressed with the work that your team is doing and kind of that you're hitting it from like multiple different angles. I think that's always impressive to me. I have a couple questions first about your multidisciplinary work group. It sounds like you guys are trying to get into more of a routine on when you guys are going to meet. Some of our teams have multidisciplinary work groups that only meet as needed, right? If there's a case review that needs to happen, others meet on a very regular basis. How is it that how are you doing it now, or what's your goal state for that group?
Well, it's pretty inconsistent right now. And we haven't gotten to the point where we're reviewing cases. So definitely I want to that's my goal, is to be able to review some of the cases and make sure that we've hit all the different, making sure that we're, giving the best care to that patient. So in all areas. So I want to get there for sure.
Okay, I'll keep going. I'm also curious, I think you're right on with the need to recruit more frontline staff. And you're right, they're pulled in every direction, right? You're often understaffed, there's turnover, right? The capacity for the frontline staff is often low to contribute to QI. Some of our facilities are looking at creative ways of encouraging participation, either through recognition on the unit with participation, or like clinical ladders programs, using their participation in this to count towards like internal QI requirements. Have you guys thought about any creative ways to recruit frontline staff to participate?
Yeah, so we do have an RN recognition program here that they'd be able to use this committee as they would get points at the end of the year, and the points, equal to a certain amount of money. So they definitely get a bonus towards the end of the year for the committees that they're in. So we'll definitely remind our staff that this is an opportunity to add this to their RN recognition profile. So I think that's great. Do you have any other ideas?
We'll keep sharing for sure as we get the ideas. I think you named quite a few of them, right? Like it contributing to internal quality improvement and recognition. I think some of our facilities have gotten really creative about the way that they're recognizing it, even if there isn't sort of an internal recognition, like giving a name to it, right? Like I am the state, our facility's state data champion, right? I mean, like I think elevating it in any way that you possibly can, and then publicizing the role that person has on the unit can go a really long way. I always like to remind frontline staff too that this is work that can be put on your resume, right? This is really important work, and it's outside of the scope of your direct clinical work. And so for nurses who are considering going on to advanced degrees eventually, right? Like going from an ADN to a BSN or a BSN to MSN, I think this is the type of work that really contributes to both like admission to those types of programs, and then the work that they probably will need to do as part of those programs.
Okay, thank you. Does anybody else have anything to add from my team that I missed?
This is Jennifer. No, I think you did a good job. I know you mentioned the NICU, and we're also just trying to identify those on each unit that are really passionate about it, to try and also have those frontline staff get other people excited and involved in it, and they can help us do some of that teaching on the units. So I know we've gotten a NICU, one of our NICU like frontline leaders that's really excited about it. So I'm hopeful that we can continue to use that to get more frontline staff.
Maybe one last question. Do you guys have any form or sort of process for communication with like the C-suite at your facility? Like, is there any form of like you guys sort of presenting the status of your QI programs, or is there support that you feel like we could offer through that?
So we have, not formally about the program, but we do meet with our CNO regularly and talk to her about the different programs that we're a part of and where we're at.
All right, feel free to continue to chat stuff in. Their team will probably be on the call for the rest of the time. And so if you guys think of other questions that you want to ask, please. If you want to follow up afterwards, again, I'm sure that Linda and her team would be happy to field questions about anything that they're doing that might benefit your teams. So we'll get back to our deck. Thank you, Rose team, for coming and presenting for us. I wanted to do a few reminders for the upcoming coaching calls. One is that it's on August 10th. So if it's not on your calendar, put it on your calendar, share it widely with your staff. Like I gave you a preview already, our data analyst, Gretchen, is going to come and give us just an overall cohort data update, right? And so we'll look at a cohort-wide dashboard and see how we as a team are doing on our screening rates and our clinical care practices. I think even though we're not going to be sharing individual hospital level data, it's an important way for your facilities to be benchmarking against the cohort. And so Gretchen's going to do that for us. And then we are going to start recruiting you. So just as the Rose team did this week, Next month, we're going to share case studies. And so any interesting cases, experiences, hospital protocols maybe that have changed, we're recruiting you. We already have a couple of facilities who have agreed to share some cases with us to learn from, but we're looking for a couple of more. And so this is our open call. We'll probably do an open call for a week or so, and then we're going to start asking targeted teams if no one volunteers about opportunities to maybe come and present. We really think that team sharing is super important, right? You guys are all in this together. You're facing a lot of the same challenges. You're trying a lot of the same ideas, and there's no way, no reason that we shouldn't be learning from what each other are doing. I want to pause and do a quick poll for you all, because in the coming months, we're going to talk a little bit more about hospital policy. Remember, we talked about those structure measures, and those are the things that sustain your work in perinatal quality improvements. And one of the best ways for you to sustain the changes that you're doing now is to either change, amend, or update your policies in your facility to reflect the work that you're doing. So we'll pause here and give you just a couple minutes. I just want a little bit of information on where your sites are at as far as policy goes. Sydney, we should have planned music for this.
I know. I was thinking about playing some Taylor Swift. I think she's coming to Denver this weekend.
I was going to say, in preparation for the big weekend we're preparing for. Next time we'll do this. Okay, we got about half of y'all responding. Thanks. We'll give it another minute here. Okay. Thanks. We got a majority of y'all responded to us. Even after the call, if you want to just shoot us a quick message about policy at your hospital, we'd be happy to integrate that into what we're planning in the future sessions. So just let us know, do you have a policy? Has it been updated? Are you interested in policy guidance at your facility? So perfect. We will move on slide-wise. And actually, I think we'll go 2 slides ahead. Next one. Yep. So we're not just asking you to come and present at the August 10th call. We're happy to give you a lot of guidance on what we're expecting. We know that just like Linda did this month, it takes time out of your day, and it's time that you might not necessarily be compensated for your daily tasks. And so we want to make it as easy as possible for you. So we're going to, after this call, send you an email with some suggested formats that you could use to present. Again, if you want slides from us, if you want us to sort of like do the back work on visualizations for you, we're happy to do that for your presentations. One of my favorite ways to present is the PDSA cycle, right? Just like Linda did today, tells us sort of exactly what you plan to do, how you did it, how you measured it, and what you're going to do about it. Another format that most of the clinicians will be familiar with is the SBAR format. So you can also use that for case studies. So again, explaining the situation of what encountered at your facility, give a little clinical background and setup for it, kind of how it was handled, and then what your team is going to do about it. And then finally, the STAR format is a really excellent one, and Sydney's linked to some details on those. So again, kind of like Linda did today, maybe 7 to 10 minutes, right? Kind of just sharing an interesting case that your team dealt with, what you learned about it, and maybe what other teams might be able to learn from that experience. So we'll share this out afterwards. If you're willing to do it but want us to create your slides, tell us, happy to support you. If you're willing to do it but would rather meet with us about it before you do it, again, let us know, and we're happy to schedule a short session to make sure that you feel really prepared to present. Okay, Sydney, I'll probably turn it over to you to finish out.
Yeah, so thank you everyone for attending. We're gonna close out now. We just ask that you fill out our evaluation form if you want CE or just to tell us how it went. I'm also gonna pop it in the chat there. if you have your phone, there's a QR code here. And then also we have this time open just for any questions about the entire session that me or Amber can answer. And then I can also pop my email in the chat for y'all to save if you need to ask me any further questions.
When is data due, Sydney? It's this weekend, yeah?
Yeah, so is actually due the 15th for Cohen SUD. So just a heads up about that. And then for those of you who are in SOAR, I know not everyone is on this call, but if you are, that due date is also August 1st. So July 15th and August 1st. We're good with questions. Everyone's okay, I can move on. Again, if you don't have any questions right now, but think of some, I popped my email in the chat, and then here's our general email address on our website. So please contact us. We're here to help you all, and we're here to make this an easier process for you. So please never, ever hesitate to reach out to us.
Thanks for coming, teams.
Thank y'all. Amber and I will probably stay on for the last 7 minutes or so if people want to speak to us, but if not, we'll just be hanging out here.
Hey, Laurel, you barely missed us. Oh, she's taking a call now.
My mom texted me and she was like, "What are you doing right now?"
You're like, I'm working. Doing my job.
Yeah. I was like, "Mom, it's a Thursday, like midday."
She misses you.
Yeah, I think she does. It's hard. How was horse camp?
Oh yeah, horse camp ended yesterday, so she's home doing chores today. But she wants one-on-one lessons now. So.
Oh boy.
I know, right? I know. Perfect. Okay. Did you stop the recording?
Yeah.
Perfect.
We'll stop sharing.